JKLIVE here at Citizen Television. What an interesting topic of conversation. Very pertinent to us all, because you know somebody who knows somebody who's been affected by cancer one way or the other, and it's not getting any better. So we have two doctors, a legislator, and a cancer warrior on the bench to talk about the way forward. Moshimo, you were saying a moment ago about pesticides and things like that, which are being increasingly used. But you are the legislator. You're the one who should be helping pass these laws.
Jeff, I'm the legislator. I don't know, in this country there are so many laws. We normally say in Kenya we have over-legislated. We have all the laws we need in this country, but they are on shelves. You go to the Pharmacy and Poisons Board, you go to all of this, the PCB, they have all what they need to do, but they don't do it. Because like PCB, they really pissed me off another day. Because how do you say that we said we'll do away with these chemicals in the next 4 years? We have already been told this chemical is causing cancer, it's causing diseases. Then you say you are trying to phase it out.
And for another 4 years.
How can you phase it out? Then you know what happened? We used to do pyrethrum in this country.
Yeah, I remember.
Serious pyrethrum farming. And pyrethrum is good when it does pesticides. You go to most export crops, you use pyrethrum on them. But we use that for export. But for local use, we use all the other now chemicals, the Roundups of this world, which is killing our people. And it's a very dangerous thing. And finally, Jeff, when you look at the issue of cost and cancer treatment in this country, doctor will tell you, if you go for cancer treatment in Kenya today, and you want to use NHIF, which the local mwananchi uses, you'll be told that will cover you for 8 units if it's a serious chemo. 6 units out of 8. Then the other one, the basic one, 4 units. Four cycles only. But now what we have done in Parliament now with the new NHIF, we have separated NHIF to 3 funds. We have the primary health care fund. Because we go to meetings and we tell people early diagnosis. But do you know screening has never been captured at the NHIF?
Yeah, that's right.
Like
so
early
you're just telling a poor man to go for screening. But screening has never been free in this country.
So he has to pay himself.
But now the NHIF we're having now, the one we are creating now, will pay for screening under the primary health care fund. Then the second fund is the social security fund for everybody. Then the third fund is for the critical illnesses and the chronic illnesses and the emergencies. Have you ever realized in this country, if a man in the village, you get an accident, and you have to be rushed to an hospital, NHIF does not cover for you. So you wonder, what was it meant to do?
Yes.
But with the new NHIF now, if you get an accident, you'll be treated.
You'll be covered.
Then with the chronic diseases, once you be treated and your cover gets finished, you have cover now gets finished. From the point your cover gets finished, now you get to the critical illnesses fund. So now we'll not have a story now of Kenyans who are going to hospital and NHIF cannot cover for their cancer treatment. That's what we have been doing for the last 1 month in Parliament. The President will be signing that tomorrow at 2 in State House. That we'll have a new fund in this country. You go to health center and you are screened for breast cancer, NHIF pays for you. You want to be screened for any cancer, NHIF pays for you. That's what the President will be signing tomorrow at 2. So we have done too much that will change the whole sector of this country.
It's going to change. It's going to happen.
Yes. Do you know NHIF currently, Jeff? The people in the local village.
No.
If you go to a health center, if you go to a dispensary, if you go to a level 3 hospital, it doesn't pay for you. It only pays after level 4. So by the time you are going for level 4, you are too sick.
It's too late.
But now what we have done now, it will pay for you from dispensary.
With tomorrow's signing.
Yes, from tomorrow's signing.
Dr. Meli. Okay, you were telling me earlier on there are 69 registered oncologists in Kenya, right? 69.
Correct.
But you were saying there could be more.
Yes.
There could be more who are unregistered, but they're oncologists. So someone is in a remote part of this country, and they want to get access to early screening or whatever it is. Where do they go? If according to the National Cancer Institute, where do they go?
Well. Thank you, Jeff. That's a good question. Now, I look at cancer care as not only an issue around an oncologist. It is actually the entire healthcare system.
Whole spectrum.
We are looking at healthcare workers, including those who are deployed to level 1, facilities, which are dispensaries. If you're a clinical officer, or you're a medical officer, or you are a physician, or you are a nurse, laboratory technician, pharmaceutical technologists and technicians, who most of them work in level 1, level 2, level 3 hospitals, we are equipping them with knowledge, with information, so that they are able to detect early. Because an oncologist comes on board only once a biopsy has been taken and a pathologist has confirmed there is cancer. But before that, it is all these folks we are training in Kenya Medical Training College, our medical schools, and all the other training programs within the country. So they should be able to access this information. But one thing, Jeff, that is interesting that I want to mention at this point is our healthcare seeking behavior in this country is very interesting. Most of us fear to even go for screening.
Correct.
We are here tonight to create awareness that please don't fear to go for screening, because this is how a life can be saved. People are worried that what you don't know cannot
hurt you.
But remember, with cancer, it's a totally different story. You got to know, and not only cancer, most of non-communicable diseases should actually be screened. So in our sub-counties, in our county governments, there are institutions. And remember, health is devolved. So we are here to provide technical assistance. Among our functions at the National Cancer Institute of Kenya is to advise Cabinet Secretary of Health, Ministry of Health on priority interventions. So if we notice in a county that we need a particular center to be established, we come in and we establish those centers. And
the funding is there? You get the funding? Or?
Well, we know resources are limited, but I would really want to appreciate, again, through our Ministry of Health, this government, because more than 10 years ago when I joined the practice, we only had Kenyatta National Hospital with one machine, old-school technology, unfortunately, called Cobalt, to be part of the comprehensive cancer treatment in this country. But as we speak right now, we have 6 national hospitals that provide comprehensive cancer treatment. Once diagnosis has been made, our people should be able to get care in a comprehensive center where they can receive either chemotherapy, radiotherapy, or surgery, the major modalities of treating cancer. We have KNH, we have KUTTRH, we have Moi Teaching and Referral Hospital, we have Nakuru Regional Cancer Center, we have Garissa Regional Cancer Center. For a long time, the northern part of the country have felt marginalized, but right now, the counties around that area can receive treatment. We have Coast General, and we are now working towards setting, more in Meru. Our priority right now is Meru, Nyeri, Kisii, Kisumu, and Kakamega. These are going to be regional centers. We are here as NCI to also advocate for access, availability, and not only access and availability, but quality services.
Dr. Busakhala, let me ask you this. In some instances, a lot of people complain about this, right? Misdiagnosis. Yes. You go for checkup, and they tell you, oh, you need malaria.
Yes, yes.
Right?
Yes.
You go home, you take Malarican, whatever it is. A few months, you come back later.
Yes.
It's back again.
Yes.
Misdiagnosis. Yes. What needs to be done? Is it more professionals to be trained? Because Dr. Ari here says it's a whole chain, it's an ecosystem.
Yes. Yes.
So
yes.
For early detection, what needs to be done?
Good. Yes. So the problem of misdiagnosis, unfortunately, is not just a local problem. This is a global problem, and when you read, even in the best of countries, you will still get cancers that were missed. And the reason for that has a lot to do with the available technology. For us here, we say the index of suspicion. So when you asked Dr. Medi, somebody who is in a place where there is no oncologist, where do they go? The answer to that is go to the nearest health facility. They will direct you. Now, in that nearest health facility, you want to find a healthcare worker who has a high index of suspicion. This high index to think that this is malaria, but it could also be cancer. This high index of suspicion could also be helped if the patient also thinks that this could be cancer. It is very, very important for that. Like Alela here says, she comes from a family history. You know, she has a strong family history of cancer. That is something you should volunteer to your healthcare practitioner when you go there. It should come from you. Once you say that, his index of suspicion is aroused, and he will start thinking in that direction. But if you don't disclose all this information, it is possible that even the best trained doctor will only think about the most likely, or the commonest problem that is occurring at that particular day. So that is at the level of interaction between you and the doctor. Then there is the next level where there is diagnostic facilities, the technology that is available to you at that particular point. Right now we have very advanced technologies called PET scans. Previously we didn't have. And it's possible that even without a PET scan will pick something that another, say an X-ray wouldn't pick. And so that is a misdiagnosis. So if you don't have a PET scan and you only have an X-ray, for example, an X-ray will miss what a PET scan will pick. That's also another form of misdiagnosis. And then we have these specialized molecular tests. We call them immunohistochemistry, we call them flow cytometry. These are specialized tests that some of them are not even in the country. We are outsourcing some of these tests. Recently, some of them have now started being brought in the country, and we shall talk about that as we go along.
Absolutely.
Thank you.
Evelyn, if it wasn't for early detection, would that have been worse for you?
Absolutely, because early detection improves the prognosis, and the treatment is even is simpler. Because, for example, if when I discovered the lump, it was limited to the breast only. If I had waited longer, the cancer might have spread to the lymph nodes on my armpits. That means that I'll need more treatment, longer treatment. So early detection, yes, does improve the outcomes. So the hashtag is early detection saves lives. And so what I do is every first or second day of the month, I post on my social media platforms encouraging women. The hashtag is feel them on the first. So reminding women and men to remind anybody around them to check for any lumps or any abnormalities in the breast, because like the doctors have said here, diagnostics is key. And this can only help if I go early when I have just discovered the lump is probably really small, which means that in some cases, surgery alone and radiotherapy would be enough to treat this patient.
Right.
Yes, there are patients who don't have to go through chemotherapy because they discovered the cancer at a very early stage. So this is, I think for breast cancer especially, that is the #1 way to reduce the deaths and the burden of the disease.
Yeah. In your WhatsApp group with these survivors, warriors,
yes.
What do they give you horror stories? Or are there stories where, the breast was leaking and they didn't get enough treatment and they don't know what to do and the chemo is too expensive? Do you get those horror stories?
Yes, there's lots of those horror stories, and not just limited to Kenya, because I'm also in foreign support groups with women from the West who are even in advanced settings. So it's different for everybody. There are cases where it was just a little lump and that was it. There are cases where it was painful. And I have not encountered someone who has really reached that stage where the breast became a wound, but I've also read about cases where the patient waited so late that the breast became a wound. And I think in such a case, it is too late to, one, save the breast, and at that point, it may have spread to other parts of the body, complicating the situation further.
Yeah.
Jeff, allow me to add my voice to that.
Yeah.
60 to 70% of breast cancers in this country presents at stage 3, stage 4. More often, the likelihood of being cured for stage 3 breast cancer is less than 20%. Wow. You look at every 80 patients that present to you, it is part of the advanced breast cancers. And it is the same also in the other cancers. Most patients present late diagnosis. And the assignment that we have at the National Cancer Institute of Kenya is, how do we reduce the stage 3 and stage 4s, which are not curable, to stage 2s and stage 1s, which are curable? You know, in the clinics, we've seen patients who present with huge fungating, bleeding, smelling, lesions. It is even stigmatizing. Cervical cancer, most patients would even fear to disclose what they are going through, and they end up presenting late. So we are here, and the cure is more awareness. The cure is more public education. And this is what we are bringing out to the public now, that please don't be silent. Go for screening. We have mammograms through the MES program or project from 2013. Every county has 2 mammograms, but they are seriously underutilized. The viewers who are watching us tonight, we are asking you, use those facilities. We know that there is a challenge of human resource in some counties, but right now we have, technology. We are leveraging on, telehealth, telemedicine. A technician in Taita Taveta County can take an image and send it to a qualified radiologist who is in Nairobi, and should be able to give feedback. And these are ways of, reducing the challenges that we have with human resource in our counties, so that we can diagnose those cancers that can be screened. Remember, it's not all of them, because someone will ask shortly, how do you screen for brain tumors? So we have breast cancer that we have screening programs, and it's very simple. Some of them is just clinical breast exam. For the young ladies, we are not asking you to do a mammogram, because their densities in their breasts are quite high, and if you do a mammogram, you will miss a lump completely. Dr. Alela here, you would not do a mammogram in her. She's young, she's premenopausal. Their breast densities are still high, though in some few, you may want to do combined ultrasound and mammograms. We are asking you for prostate cancer. Jeff, have you done a PSA?
I do, since I was 40.
Jeff, I want to interrupt Dr.
Hold on. He asked me a question. No. I want to put it on the record.
Keep doing it. Yeah. It's quite important.
Why I want to interrupt Jeff? Yes. There are cancers, we are doing awareness.
Yes. Yeah.
And when we are doing awareness is about the simple messaging. When we sit here today, I'd want to do awareness to Kenyans. We are not doing awareness to fellow doctors. We are doing awareness to my mother.
Yes.
So it's simple messaging. Simple messaging is, as we say for breast cancer, you feel a lump. We need to tell the woman in the village that the lumps you feel in your breast are not as effect of family planning. Because that's what most women say. Yes. I felt that lump, but I felt it. My hormones, they get imbalanced now and then.
Yes.
That's what we need to tell our people. We need to tell our people that a baby coming home feeling tired and doing a little thing and feeling tired might be a problem. So we need to tell our people, for men, what are the telltale signs for men, Dr. Ali? We do very simple messaging for our people for awareness. Because like women at breast cancer, they will tell you it's hormones, these lumps appear every month, it's because I took some family planning. And finally, if you talk to any Kenyan and cancer treatment, they will tell you, I'm coming to Kenyatta, or I'm coming to KU. Is the early time NCI, Dr. Ali, we told people that we are treating cancer in Coast, in Mombasa. Is the early time Kenyans know that we are treating cancer in Garissa? Is the early time Kenyans know that we are treating cancer in Kisii? Because you're crowding
Nairobi
finally.
Yes.
I think just one thing on why we encourage women to check their breasts every month is because we want you to know your normal. So if I check my breast every month, then I know what my normal breast feels like. So on that unfortunate day that there'll be something that is wrong, then I will know that I didn't feel this last month. So that is one of the way we can say we are talking to the common wananchi, that it's nothing complicated. Just know your breasts, know how they are on the normal day, so that day when there is examine it. You know, we even teach and have the images of how to touch and what to look for. So if I've been doing it constantly for even up to 6 months, I know what my normal breast feels like. So it means that the day when there'll be something, I will feel, and it will be early, and we'll be talking about maybe stage 1 or 2, where it is curable.
Dr. Busakhala, how do men check? Since women are checking breast, right?
Exactly.
How do we feel our goods? We're talking to machinery, right?
Yeah, that is right. So, in terms of prostate,
yes.
My advice to men is take time once a year and go and see the nearest, go to the nearest facility and ask for a prostate test. Have a discussion with the person nearest to you. I'm very excited with the news from Mheshimiwa that NHIF is going to start paying for screening.
Early screening.
Yes. The simple message is let everybody use this opportunity just once a year. Go to the nearest facility. Don't bother whether that facility can screen or not. Because when you go there, you generate demand. That facility will notice that people are coming here every day and asking for this.
Yeah.
So let us bring it, you see? And so people should not walk long distances looking for screening. As I said, PSA, you know, prostate specific antigen, which we use to screen for prostate cancer, is the interpretation must be very personalized. It cannot be generalized. We can never say PSA at this level do this. It will be doctor and patient on an individual basis.
And can it vary from year to year?
Yes, it can vary from year to year.
Yeah.
In fact, today you can go and check your PSA, you find it is 8. Next year you go and check, you find it has come back to 4. It is possible that you can get those fluctuations. Or you can see it consistently going up. So for men, this must be very, very personalized. Go there, go to the nearest place. This is my point. Health care, access to health care has been shown consistently to depend on distance to the healthcare facility. Yes. The closer the healthcare facility, the more people use the healthcare facility. So my advice to all men and women is that set aside 1 day per year and go for medical checkup to the nearest facility. Yeah. If they cannot do it for you, they will direct you. But you will have shown them something.
Sure. Dr. Melly, there's a question that a lot of people are asking, especially adolescents, young women especially going through hormonal changes. And they go for checkup and they're told, you know, this is part of the hormonal, it's adolescence.
Yes.
But it may not be.
Correct, Jeff. You know, we have mentioned here that we really need to have our healthcare workers to be, you know, trained in an environment where they have to have a very high index of suspicion. And that is why the quality of training in our training institutions, our medical schools, should really be top-notch, so that we can equip our healthcare workers on the right information. Yeah, it's so sad that recently I actually had a 16-year-old girl who was dismissed by many doctors that, you know, you are pretending, you are having malingering syndrome, yet these were telltale signs. You know, so we are asking our healthcare workers, and I'm glad today in Kericho, it was a Human Resource for Health Day sensitization, and we really have to keep improving. There has to be continuous professional development amongst healthcare workers, cutting across those who participate in the entire continuum of care, from prevention all the way to treatment, with either curative or palliative intention, including survivorship. Because there is new knowledge, Jeff, that comes out every now and then. And you would allow me to mention that as a country now, we are really going into cancer research to answer our local questions. You did ask earlier on whether cancer is cancer. Of course, there is evidence that due to our disparities in our genetic makeup, it could be one of the reasons why there is also differences in outcomes of cancer treatment. It has been scientifically proven that, you know, women of African descent have more aggressive breast cancer than the Caucasians. So how about Kenya? We are different from West Africa. So through the National Cancer Institute of Kenya, we are actually putting in now more resources into cancer research, and we are asking the government, we are asking through the National Assembly to allocate us more resources so that we can answer our priority local questions that people are asking. How many of these children, these adolescents, because they are going through life, and it is good to also know what are the exact symptoms of, a girl who is going through, adolescence. What are the changes? So if you are a doctor, if you are a healthcare worker who has a high index of suspicion, you should know when to say this is okay, it's normal. And you should also know this is not right. And through research, I would like to look at the success of treating cancer in this country by considering everything from a research point of view. We are collecting data. Why are more adolescents presenting in this way? Why are more people in the western part of the country having more cervical cancer, and there are less in Nairobi? Is there any relationship to the risks they could be exposed? HIV is big in affecting our immunity, which then it makes the cell that has had an error to escape, the mechanism, the checkpoints. Immunity plays a very big role, genetic instability. We want to know all this so that these patients who are asking, why me? We need to profile them. We have talked about, we want to, raise the bar of cancer war to the genetic level. And we are, sensitizing also the government to invest on what would really address the major public health burdens in this country. And I would always mention the big five. We need to really, as much as it's important to address, everybody who is diagnosed with cancer, the reality is we have to make sure that we look at what takes, the 80-20% effect, because we have 5 major cancers that actually has 80% of the burden in this country. Breast cancer for women. Cervical cancer that should not kill any woman in this world. Remember, 99.7% of cervical cancer is caused by HPV. We now have a call to action to eliminate cervical cancer by 2030. And we are asking that HPV is human papillomavirus, which is transmitted sexually. So we are asking that 90% of our girls, by the time they are 15 years, they should have been vaccinated. But we have a very big challenge we are now at less than 20%, yet we are being called to vaccinate 90% of our girls by 15 by 2030. And those who are, we are also asked...
as you go on, and what is the resistance? What's the main resistance for that?
So the challenge here is, cultural beliefs, myths, that if you're going to vaccinate my daughter, their biggest worry is infertility issues. We want to procreate. We were asked to go ye and fill the world. And
multiply.
Yeah, yes. So, even healthcare workers. Yeah. So we really need to do a lot of education on this. And we are asking, our mothers, we are asking parents, allow your daughters to be vaccinated. It has worked. Australia is going to be the first country in this world to eliminate cervical cancer. They started their vaccination in the 90s. Many other countries are joining. In Kenya, through NCI, we're going to create more public education and awareness. I just mentioned that 70% of our women, by 45 years, they should have undergone screening. And now we are making even better, more comfortable. Women can now do self-collection of the sample because this is more comfortable to them than undergoing these uncomfortable procedures. And 90% of those who are diagnosed with precancerous, those lesions that are not cancer yet, or even if they are diagnosed with cancer, they should be treated. If we do this, Jeff, by 2030, we will join the countries that will eliminate cervical cancer.
Okay, cervical was number 3.
Number 3
Number 3
is cancer of let me mention men. Prostate cancer, number 1. All right? Yeah. Then for adults, both gender, we have cancer of the esophagus. Do you know, Jeff, if you are diagnosed with cancer of the esophagus this year, more than 80% of those patients will be dead within 1 year. This is actually number 1 cancer in causing mortality in this country. You just struggle with swallowing.
Yeah.
You know, because it has a lot of nutritional challenges. And when you have nutritional challenges, then you have other many complications. You know, you lack micronutrients, you lack macronutrients. And if you, this will affect how the cells are functioning somewhere else. And we are here, you know, the esophagus, this feeding tube is so tiny and so tight. By the time you present with difficulty in swallowing, actually the disease is stage 3, stage 4. And if you don't get surgery for cancer of the esophagus, forget it. You know, so we are also sensitizing. That is why we are saying, if you are unwell, please present yourself to the hospital. Don't go to the herbalist.
So if you have trouble swallowing, you go straight to the doctor, or maybe you just had a bad meal?
Well,
maybe the drink was too cold.
But then,
I'm not making like this.
I know there's also association with even drinking hot tea as a potential challenge.
Yeah.
What we are saying, the healthcare workers are available for you. You know, it doesn't cost you anything to ask, and it be clarified to you. So we are having also colorectal cancer coming top, you know, 5. And we are now seeing a big rise on the other head and neck cancers. I won't forget to mention children, okay? Because these are our babies. Number 1 is acute lymphoblastic leukemia. These are blood cancers. We are seeing lymphomas. These are cancers that affect glands that would be in our armpits or would be in our groins. Some of them are even internal, you know, glands. We all have them. They assist in fighting against infections. But when they enlarge, then make sure you see a doctor. I'm not saying if you have an enlarged gland. I don't want to be misquoted, Jeff. If you have an enlarged gland, doesn't mean that you have cancer.
Correct.
You need to seek, you know, assistance from the hospital, and the doctors are going to clarify to you. We have cancers of the kidney. We are asking mothers, please, when you are birthing your babies, examine their tummies. You know, they are very soft. While you are birthing this, you know, with children, we can have even as young as 2, 3, you know, for a long time, cancer of the kidney for children. It's called Wilms tumor. In a more complicated language, it's called nephroblastoma. You know, a disease that can be treated with surgery if picked early. But unfortunately, we have picked it when it's stage 3, stage 4, and we have these little ones being, you know, treated with a lot of chemotherapy, a treatment that protracts to even 38 weeks. A little 2-year-old, you know, weekly chemotherapy. They get radiation, they get surgery. This is one of the top cancers in children. Brain cancers, we are now going to work with Ministry of Education in schools to sensitize the teachers as well, so that they are able to pick it up from our children. We should not condemn our children when they are not performing well in class. Sometimes it's not their fault. We need to connect them to healthcare.
Right.
So this is the burden that we are talking about, Jeff. It is real. It is tough. Yeah. We have to have, you know, a serious discussion. And if you look at the approach Ministry of Health has taken right now, we have a national cancer control strategy, which has 5 pillars. If we're going to implement this strategy, the latter, the National Cancer Institute of Kenya is leading in its implementation. We are looking at, you know, prevention and early detection, pillar number 1. We are looking at proper diagnosis through laboratory, you know, diagnosis, and also radiology and imaging, the scan world. You've heard about PET scan. Those are the most, you know, and we have it here in this country at Kenyatta University Teaching and Referral Hospital. We want to make sure after we have diagnosed, pillar number 3, very important for the public to know that tumejipanga, we really have a strategy, is treatment and survivorship. Because it doesn't stop with treatment. Jeff, a lot of these patients after treatment, they go through a lot. Mentally, physically, some of them, their bodies are distorted. Some of them cannot, there's something called chemo brain. It makes you not to think right. they should be recognized. Some of them need rehabilitative medicine, integrate them back to normal life. We have a pillar number 4 is on resource mobilization and healthcare financing. We need resources so that we can address this challenge. And the last one is cancer registration and dissemination, information. I mentioned earlier on that data is the new oil. If we have this data and we use very well for planning and for cancer research, this is a strategy that is cost at 49 billion. I'm happy at least I'm here with Honorable Ndwinga Munene. You know, the National Assembly allocate resources. But then we also are going to think outside the box to do resource mobilization so that over the next 5 years, we implement this strategy. And consistently, we will be having, you know, monitoring and evaluation.
Yeah, okay. Mheshimiwa.
Yes, Jeff. I was almost interrupting. It almost became a lecture. And I'm not very good at lectures. You know, Jeff, I want to challenge my brother. You see this lecture he is giving us, how we need to see this cancer, to see this cancer, to see this cancer. The national government and through the county government, they have formed up a very good structure, actually. We have these community health promoters. Let's not say we have taught them, we have not, because I live in this country, we have not. I want to challenge the National Cancer Institute to call, because we can't have enough oncologists in this country. We have agreed that. And an oncologist comes at a very high level. So I want us to, Dr. Ali, we only have 47 counties. And these people have already been clustered now. Can we develop a curriculum? Can we call experts, oncologists? We have Dr. Ali, who is also a lecturer. Dr. Ali, can we develop a curriculum?
It is there, Mwesh.
A curriculum that will go to the community health workers with, the promoters with, and teach them well on this early detection. Because now we are saying the screening has been made easier. Because initially, politicians used to tell people in barrios, go for screening. But we are telling them to go for a screening, which we are not paying for. We are telling a family that slept hungry to go for screening.
And so they have no money.
So they ask themselves, do we go for screening or do we buy food?
Right.
But now with the government providing that for free now, we only now need to have knowledge at the local level, at the dispensary, on what they need to detect and what are the danger signs. If we can do that, at detection will be at a very high level. And finally, Dr. Ali, you know, when we say legislators need to legislate, like on the issue of pesticides, by the time I list to Parliament and they say pesticide A, B, C is cancer causing, there need to be a research on that.
Correct.
That you study in Parliament and say, as a country, we need to ban pesticide A, B, C, because it's causing this and this cancer. So our scientists need to work on that and provide us with that and tell me today that this pesticide, we need it off the market. This pesticide, we need it off the market. Because anything else becomes witch hunt for the big companies and the multinationals. Yeah. So we need to profile these pesticides, which I think that is possible with the kind of education we have in this country. And say we need to do away with this pesticide and this and this. Because most of the research we're relying on, Jeff, right now is from Europe, fallen, that they embed this because of this. They embed like Roundup. Roundup has been banned all over.
And it's here.
But here it's common, every farm use Roundup.
Dr. Busakhala, you agree? Do you agree with this?
Yes, I agree with him. The first aspect of community health promoters, this is an issue we prepared for many years ago. And it's been campaigns, and now we are happy that they are on the government payroll. Initially, they were community health volunteers. And we already developed a curriculum for them, and not just for cancer, but also for hypertension and the rest. The second thing about cancer-causing chemicals is that we do not need to rediscover the wheel. If there is evidence in the US, if there is evidence in Europe that this chemical can cause cancer, we do not need any other evidence here. Let us use that evidence there. That's called due diligence.
Right.
Yes, so let's just use what exists to make decisions and move forward.
Absolutely. Folks, we have a lot of feedback from our viewers, lots and lots of feedback. Let me go back to the magic wall and see, let's take a look at some of them and see what they're saying. Janet Kyoko says, I'm a cervical cancer survivor currently living in Kitengela. Yeah. To me, I thought cancer was a disease of the rich people. My thinking of those days. Until it came to me. The process is not easy, but I'm alive today and I can testify. You hear the misconceptions, huh?
Yeah.
Cancer is a disease of the rich people. Sir Nixon Nugita says, at one time in the year 2016, the government raised the alarm over continued use of asbestos tiles for roofing after its components were found to contain cancer-causing elements. Was this really a fact? Because we still have those roofs to date. Oh, yeah. Mushima, asbestos tiles, huh?
Yeah.
Yes, asbestos are bad.
Anything asbestos?
Yes. Even the brake pads for vehicles. Previously, it was laced with asbestos. And it is one of the leading causes of lung cancers called mesotheliomas. Yeah. So it's very important that, again, and these ones have been banned in this country. Unfortunately, sometimes things fall in between the cracks, unfortunately.
And the most funny thing, Jeff, you find most schools that were constructed a long time ago, 70s. Yes. And those are the most primary schools we have. Most of them has asbestos roofs. Yeah. Most dispensaries at the center, you find you are being treated in an hospital with asbestos.
Oh, yeah. Felix Kiprono says, I lost my dad to esophageal cancer last year, and since then I've kept wondering, how long does cancer stay in the body before it progresses into late stages, which I understand is when most cancer cases are diagnosed in Kenya. You heard that, huh? How long does it last, huh? Okello Molemu says, Jeff, can your perfectly balanced panel comment on the magnitude of impact or lack thereof of medical equipment scheme in the fight against cancer? Secondly, can they opine on what should be done to encourage more people to be screened? I think we talked about that, yeah? Encouraging people and making them aware, right? Yes. Anonymous says, my daughter was diagnosed with acute lymphocytic, is it? Yes.
Yes, correct.
Leukemia in 2021, December, at Kenyatta National Hospital, and was immediately put on treatment. And I can say, in early diagnosis, one can respond well, because my daughter is doing okay, thank God for that, though her treatment plan is ongoing up to the end of 2024. Kudos to the pediatric oncologist team at Kenyatta National Hospital. Wanafanya kazi. Wow. But the treatment will go on here till 2024,
yes, right? Yes, maintenance. It's in different phases.
Wow.
Yes, yeah.
Peter Jiroga says, Jeff, doctors should be forthright and tell patients and caregivers when it is no longer viable to travel for further treatment and rather focus on home-based care to improve the quality of life. Recently, I lost a brother to leukemia at MTRH, who only stayed in India for 2 days, really draining to friends and family. That's very true, huh? Yes. We always think it's better to go to India, it's much better. Yeah. But at the end of the day...
Exactly.
Engineer Maiga in Mombasa says, Jeff, please ask the panel, why do citizens from Asian countries, example Japan, have a high life expectancy?
It's lifestyle.
Busakhala, you're laughing. Is it the sushi they eat? Is it the raw fish? Or what is it?
Yeah, it's a lifestyle issue.
And diet?
Yes, it is. It combines diet. Most of the people in the so-called blue zones. I don't know if you've heard the concept of blue zones. You know, places like Okinawa in Japan, you know, the SDA village in California, this village in, is it Icaria? Icaria in Greece, and some place in Italy. Those are places where, you know, people comfortably live up to 100 years old. And there is a lot of research, and it comes down to lifestyle. You know, these people are active, these people eat healthy food, and these people take adequate rest, you know, and these people don't smoke. These people have a healthy relationship with alcohol. So all those
a healthy relationship.
Healthy relationship with
I like that. David Spara says, according to the guests, we diagnose exact cause of mutation, then target treatment. But how about simply eating a sound vegetarian diet with no box-based or can-based food? Get your sleep. get your supplements, avoid sugars, salt, smoke, alcohol, meat. That's it. Hey.
Fair enough.
But there are people
Good guide.
Okay, another anonymous says, I have a dripping breast. It drips brown liquid, although not regularly. Could it be a sign of cancer? Although I am also approaching menopause.
She needs to
Naftali.
be checked immediately.
Well, this is a good question. And what we will ask the anonymous writer is go to the nearest health facility. You will meet a healthcare worker who would listen to you, what we call history taking, examine the breast. And if they can provide a plan of care for you, they will. If not, let them refer you to a center that further, investigation.
And she shouldn't be afraid.
She shouldn't, but she should seek care.
Yeah. Yeah. Okay, one final one. Beatrice here says, just a concern. Can Our Lady survivor, actually you're a warrior, not a survivor. No, you're a warrior, may recall on her previous lifestyle or diet that she might suspect caused that?
My
you don't have to tell us about alcohol.
I was very active, exercising.
Yes.
I watched what I ate. Definitely not 100% like the Japanese.
Yes.
But compared to the average Kenyan, I was doing very, very well. So in my case, because of the genetic predisposition, which was found in my history, I was advised to have a genetic test.
Yeah.
And I came positive for a breast cancer mutation, which means that I was already predisposed to getting breast cancer. Exactly. This, however, doesn't mean that everybody who has the mutation gets cancer, because I think it is shown that only 5 to 10% of cancers have a genetic predisposition.
That's right.
So I could say I was just unlucky.
Yeah, that's right.
Unlucky.
Yeah.
Let me ask you this. Do you have any children?
I do.
Do you have any daughters?
No. Biological, no. But so what came out of what I was told now after the BRCA, the breast cancer mutation, when I was positive for it, it meant that now my primary relatives, that would be my nuclear family, my sisters now have to be more keen on screening. So like my sister who is 40 needs to be very, very serious with her annual mammograms. And then the younger one needs, because usually these screenings are not done to women under 40. So because of the genetic link that she has, then she qualifies to even have an ultrasound or in some cases an MRI just to check, because this mutation means that it is likely to get breast cancer at a younger age, because traditionally breast cancer was an older woman's disease, but now it is getting to be found more and more in younger women. Then I was also advised to have my brothers also be keen on their prostate health as well. So they also need to be very keen on having their screening.
Right. Let me ask a question, and I think you answered it earlier, but let me ask again. Dr. Can a person be declared cancer-free after surviving, after being a warrior? And after how long? Is there a grace period? Is there a time period?
Well, we have many public personalities in this country and in the world who have declared that they are cancer-free.
I spoke to one not too long ago, a former senator.
Yes.
I watched, and it was a good show.
Thank you.
Yeah. You can actually be declared cancer-free. Now, what we are advising our patients, and I would really want our viewers and those who are listening to us to take this keenly. When you are diagnosed with cancer and you undergo treatment, the follow-up sessions, after treatment, you will be given a follow-up plan. After completing active treatment, you will get a follow-up plan, either to be reviewed by your doctor once every 3 months, once every 6 months. And we graduate, the first year we would want to see you more often. And what we are looking at in the first year is telltale signs of possible recurrence. And remember, when we are discussing cancer care with patients, we discuss prognosis. Prognosis is what are the likely that you are going to be treated with curable intention, the likely risk of recurrence, all that is discussed if you are being treated by a competent, well-qualified, updated oncologist. So that, you know, she mentioned here that she was told she's triple-negative breast cancer, and the risk of a triple-negative breast cancer is different from a hormone receptor breast cancer. You know, we should discuss these things bare. And while we are discussing with them, those who have higher risks of recurrences, we can map them. We can then follow them more closely. And after the first year, we would want to prolong, you know, the follow-up period if there are no evidence of recurrences. Right. So the first year, if you are going to go through imaging and it's found that there is no evidence of disease clinically or through images, we refer to that as you are in remission. Okay? But then we would want to hope that you will be in remission with imaging all, you know, the time when scans are being taken. The first year, the second year, the third year, the further away from your treatment and you are not having any likely recurrences, it's unlikely that you will get a recurrence. Yeah. After 5 years, we are likely to, you know, confirm that you are cancer-free. Yeah. When a patient completes treatment and immediately they get the first scan and they were all happy smiles, of course we wish them well. They're excited that I'm now cancer-free. Sometimes it can fool us. You know, after 2 years, boom, a patient has headache or a cough. You go to the doctor, you get an image, and fortunately, you see lesions inside there. So we are encouraging our people, but we are even extending follow-up now beyond 5 years. So really, your relationship with your oncologist is going to be longer than 5 years.
Right. It's a long-term relationship.
It is permanent.
It's like a marriage. Lady, gentlemen, have some final thoughts. I think I've taken over your time. Look at this. It's midnight, and we are still talking. Mheshimiwa, final thoughts moving forward.
So my final say, Jeff, as the Vice Chairman of the Health Committee in the National Assembly, is to tell Kenyans that tomorrow, 3 very important things are happening in this country by a stroke of a pen. One, we'll start paying for screening, NHIF, because we have talked about this screening, adult screening, and people have been asking us, that's a luxury to us. How can we pay for it? So from tomorrow, that will start happening. That you will walk to a health center and you'll be screened and it will be paid for by government. The second thing that is happening tomorrow, we are having the primary health enshrined in our constitution, that these promoters will be in your villages. They will be paid, they will be trained, and they will be available for you. So you don't have to wait to see an oncologist to be told that there's a problem and to enter the health system. That thing that is happening tomorrow, by a stroke of a pen by the president, is that we'll stop telling our patient that we can only pay for you to this level of treatment. Because now I already have cancer, and you are telling me I can only pay for you 2 cycles, 4 cycles. So what do you want me to do? So tomorrow, by a stroke of a pen, that will be sorted. That you'll be treated for cancer, and government, through NHIF, will take care of that. Finally, as Dr. Ali said, a very important point I don't want to forget, he said he's going to work with schools and train our teachers, because that's where we are losing children. That our teachers also need to know, because the child is not with the primary health care and the promoters most of the time, but with the teacher. So with training of our teachers. And finally, I want to tell Dr. Ali, yesterday I was talking to someone and he told me, this National Cancer Institute you people have formed is working very well. And I was telling him it has been there, but he told me I've heard about it the other day. So I want to tell Dr. Ali, for the last few months, he has done very well. Thank you. He has done very well to bring cancer to be discussed in this country. You know, something is sorted when it starts being discussed. Correct. So Dr. Ali will just encourage you, in Parliament we'll add more resources, but continue fueling the discussion on cancer.
Absolutely. Good point. Very good point. Dr. Busakhala, final thoughts.
Exactly what he has said, that, you know, now that NHIF is paying for screening, this is a huge milestone. You know, I got this news today during the stakeholders meeting, and it's very exciting. This is major. And
it's a game changer.
It's a game changer. And we would encourage Kenyans, wherever they are, before October ends, visit the nearest facility for a health checkup.